right. Good afternoon and welcome to the Department of Medicine Grand Rounds. I'm very pleased today to introduce, I don't know why I'm echoing, but that's fine. I think we'll carry on. Introduce our speaker, Dr. Smitha Pathayappura. Dr. Pathayappura is an assistant professor of medicine in the Division of Dermatology. She's a full-time dermatologist at McMaster University Medical Center, mostly at the Boris Clinic. She completed her medical school and residency training in dermatology, venereology, and leprosy from India. And following that, when moved to Canada, she completed a dermatology fellowship at McMaster University, focusing on contact dermatitis, phototherapy, and advanced occupational medicine. Her clinical interests include cutaneous manifestation of systemic diseases, and this is very useful for us in medicine. And today she's going to speak to us about an overview of dermatological concerns in diabetes mellitus. I'm very eager to learn a little bit more about that from Dr. Pathayappura today. And without further ado, I will let Smitha go ahead. Smitha, please go ahead.
Thank you, Dr. Azam, for the kind introduction. And thank you for giving me this opportunity to talk to you today at the Internal Medicine Grand Rounds. And thank you all for joining today's session. My topic, as Dr. Azam told you, is an overview of dermatological concerns in diabetes mellitus. I thought I'll select this topic because it would be very relevant for both the internal medicine audience and the internal medicine subspecialty audience here today. So we'll start off with the presentation. So before I begin, let's all take a moment to reflect and acknowledge. We at McMaster and affiliated hospitals recognize that the lands in which we provide care are the traditional territories of Mississauga and Haudenosaunee nations, and within the lands protected with the Dish with One Spoon Wampum agreement to peaceably share and care for the resources around the Great Lakes. I have no conflicts of interest to disclose. So before I begin, I will start off with a quote from Sir William Osler. I think it's very relevant here in today's topic. In quotes, there are in truth no specialities in medicine, since to know fully many of the most important diseases, a man must be familiar with the manifestations in many organs. This quotation is very relevant here, and I think knowing about the skin and diabetes is a very important clinical thing, and it can be very useful, and it can add to your clinical acumen. On that note, let me go over with the objectives of today's presentation. The first one would be to identify some of the key skin conditions which are associated with diabetes, particularly the specific and also the non-specific ones. Secondly, to recognize some of the cutaneous adverse effects and reactions which are linked to anti-diabetic medications. So many new anti-diabetic medications are in market today, and also the diabetic management devices. And last but not the least, let's all appreciate the importance of early and adequate skin care in prevention of complications. Adequate skin care can be very important in diabetes, and it can be a good healthcare investment. Coming to a background, diabetes, as we all know, is a multi-system disease, and it also affects the largest organ of the body in very subtle and in very drastic ways. 30 to 70% of patients with type 1 or type 2 diabetes will present with skin changes at some point in their life, which is a very large number of patients. Cutaneous signs not only aid in diagnosis, but they also serve as indicators of metabolic derangement and glycemic control. Prevention is always better than cure, so early recognition and prompt management can prevent further complications and avoid unnecessary investigations. So on that background, let's go to the pathophysiology. There are multitudes of pathophysiology and neuroexplanations for diabetes and skin, but the key highlights of the pathophysiology would be these three: changes in microvascular circulation, as in all other organs, decreased immunity, and altered collagen synthesis. These three are responsible for most of the skin changes that appear in diabetes. Inflammation does have a pathology in some of the manifestations, but with respect to the skin, these three are the highlights, the main pathophysiology, which is responsible for the changes. Moving on to some of the risk factors for skin complications, just like in other organs, poor glycemic control, duration of diabetes, neuropathy, which is a very significant risk factor, peripheral vascular disease, which impedes the vascular blood supply, especially to the lower limbs, can cause most of the lesions in the skin. The pathology is peripheral vascular disease, obesity, smoking, and medications, especially immunosuppressants, corticosteroids, and also we see diabetic patients are on other medications too, which can be responsible and risk factors for skin complications. Now I'll just classify some of the skin changes which are relevant to diabetes. Classification always makes it easier to recognize them. Specific manifestations, which are more so related to diabetes, and they are the skin complications very strongly related to underlying diabetes. The non-specific complications or manifestations, they are present in a number of systemic diseases, and particularly it's also present in diabetes. Comorbid skin diseases, those are the skin diseases which have a high incidence in diabetes. It's a separate skin disease, but it has a more association with diabetes. Skin infections, as we all know, has a very high incidence in diabetic patients. And last but not the least, adverse cutaneous reactions, which are now caused by the many diabetic medications in market, and also the management devices can cause skin changes like contact allergy, etc. So we'll be discussing the topic in these headings actually. Now we'll move on to the specific manifestations of diabetes. As you can see, there is a diabetic highlighted here, which means it has a very high association with diabetes. So we have diabetic dermopathy, we have necrobiosis lipoidica diabeticorum, bullous diabeticorum, or in simple words, diabetic blisters, diabetic foot syndrome, which you are all familiar with, and scleroderma diabeticorum, which can also occur in diabetes. Now coming to the first one, which is diabetic dermopathy. It's a very common manifestation, but more so it's very under-recognized. It is present in actually 50% of patients, making it the most common specific manifestation. It affects disproportionately men more than women, and also men over 50 years of age. It's typically a late complication. We describe it as a late complication, but it can be present at the onset of diabetes too. And mostly the patients who present have already combination of nephropathy, neuropathy, retinopathy, and associated cardiovascular disease. So the lesions, as you can see in the picture, presents as brownish macular papular spots. Sometimes it's confused with vasculitis, and it is sent to us and for biopsy. But it's a cutaneous manifestation of diabetes, and it's usually very asymptomatic, and we don't need to do much, or it's a clinical diagnosis. Management, like I said, there is no need for a biopsy. It's a clinical diagnosis. Lesions are asymptomatic and self-resolving. The only issue is we need to improve glycemic control and address the microvascular complications which are responsible for these diabetic dermopathy manifestation. Now coming to a little bit more severe one, which is necrobiosis lipoidica diabeticorum. It's a three-tier long name. So it's actually a misnomer, actually, though they have put in this name for the condition. It's actually a misnomer because necrobiosis means a state of life, and biosis meaning life, and necro meaning death. So both are like self-canceling terminology coming together. Lipoidica means accumulation of fat, and accumulation of fat is not a primary event in this condition. So it's actually a misnomer. It is a granulomatous disease, and it affects 0.3% of patients with either type 1 or type 2 diabetes. And this, unlike the other condition, it's more common in women over 30, and it appears on the pretibial area. We have a lot of lesions of diabetes appearing in the pretibial area. It's because it's a vascular compromised area, and it's that's why they say it's more common in the legs and in the pretibial area. As you can see, it presents as reddish erythematous, very indurated plaque with yellowish color. Sometimes it's confused with other conditions like pretibial myxedema or stasis dermatitis, etc. But it's mostly a clinical diagnosis. Trauma is an inciting factor, so that's the most important thing, is to avoid trauma. Even minor trauma can trigger the disease. A retrospective study for about more than 60,000 type 1 diabetic patients between Hamler and colleagues showed that there was a correlation between poor glycemic control and this necrobiosis lipoidica diabeticorum. But currently, the other evidence or available evidence in literature is actually insufficient to clearly support this claim or refute this claim. Now, coming to the pathophysiology, what causes this? Structural changes, as usual in vasculature, thickening of the basement membrane, vasodilatation, adhesion, cellular adhesion, proliferation, and gene expression. Those have all been the pathology. Inflammatory processes also work for this condition, and it can be an important cause of inflammation is an important pathophysiological entity. The complications include malignancy and secondary infection. So sometimes we end up doing biopsies for these lesions. At some area, it could change it to squamous cell, just like chronic ulcer. And secondary infection is also a possibility. Management is to improve the blood supply, vascularity, like aspirin and pentoxifillin sometimes works well. With the inflammatory pathology, we sometimes give systemic and intralesional steroids. Intralesional steroids are typically injected at the margin, and it helps in preventing progression of the lesion. Other treatment options include tacrolimus, infliximab, and platelet-rich plasma have given like good benefits. Now we move on to the next specific manifestation of diabetes, or what we call bullous diabeticorum or diabetic bulla. It's a very eruptive, acute eruptive blistering condition, and it's a very uncommon manifestation, and it has a prevalence of about 0.5% in type 1 diabetes, more than in type 2. It again tends to occur in older men, 50 to 70, and the bulla are large in size, and it can be about 0.5 to 5 centimeter, and there is always an abrupt onset, and then it's just overnight. Sometimes in inpatient wards, we see typically overnight where there is no trauma, and it just appears suddenly. Usually they are self-healing. So the importance of this is that it can be confused with other blistering diseases of the skin like bullous pemphigoid, and sometimes we get referrals to rule out other primary skin diseases like bullous pemphigoid. But this is a relatively benign condition, and usually the protocol is to leave the blisters intact because they are sterile, and there is no evidence that antibiotics or aspiration is indicated. Unless the blisters are very large, we just leave it intact, and even if they break, we just leave the roof of the blister in the skin so that it heals better, and usually no other management options is needed. Now we go on to another very unrecognized specific manifestation of diabetes, which is scleroderma diabeticorum. Scleroderma meaning thickening of the skin. There is an indurated thickening of the skin, especially in the upper back, shoulders, and back of neck of diabetic patients. And it's a very gradually worsening condition. So mild cases we sometimes don't even recognize. But in the extreme cases, it results in decreased range of motion, restrictive respiratory problems, etc. The pathogenesis is actually non-enzymatic glycosylation of collagen and proliferation of fibroblasts. So that is the pathology. Management options are sometimes difficult to manage, especially in the later stages, but emphasis should always be on prevention and strict glycemic control because the pathogenesis is non-enzymatic glycosylation of the collagen. Clinical improvement is limited in patients, like I said before. Clinical improvement is limited in patients who are already in the later stages. So therapeutic options include immunosuppressants, sometimes corticosteroids help, phototherapy helps, and physiotherapy are the options which can be tried. Now we come to another manifestation, or what we call the prayer sign. We also call it the namaste sign. In long-standing, this is again in long-standing diabetes, accumulation of glycation end products promote inflammation, and there is cross-linking of the collagen. And as you can see here, there is limited joint mobility, and the joints are actually flexed at the interphalangeal joints, and patients may have difficulty in pressing the hands together at the palmar surfaces. And then when you keep the hands together, it looks like a prayer sign. There's a flexural kind of deformity there. Now we move on to the diabetic foot syndrome, which most of us have encountered in patients with diabetes, and they make up 15 to 25% of patients with diabetes. There are actually three etiological features like neuropathic, ischemic, but most of the time they are like mixed. There's no one definite explanation, but usually it's due to vascular and neuropathic causes. They usually develop at sites very prone to trauma. As you can see, the ball of the big foot is near the big toe is a very common site. And other sites include the metatarsal heads and all that, and it's usually due to diabetes. Collapse of the midfoot can occur, and then that is due to diabetic neuro-osteoarthropathy, and this can lead to further ulceration. So that's typically what we call the rocker bottom foot. And neuroarthropathy leads to further ulceration, and it's like a vicious circle. Management, like in all other manifestations, prevention is the key, and there is the importance of daily surveillance, and adequate foot care is very important. And also there is the interdisciplinary care, which is very, very important in diabetic patients. So I'll just go through some of the highlights of management. I won't go into the details of this diabetic foot ulcers. So first, it's important to assess the cause, whether it is neuropathy or ischemia. Then ulcers, though may look very superficial, sometimes they have deep-seated and deep pockets of infection. So sometimes they recommend we need to probe with an instrument or a sinus tracts to know if there are any deep foci of infection. Plantar surface ulcers require pressure relief, and it's important to do non-weight bearing and footwear, utilize off-loading footwear and appliances. Clinically, these ulcers do not require culture or antibiotics. But again, when we see deep-seated infections and there is positivity on the swab, sometimes we may have to start them on broad-spectrum antibiotics. And antibiotics cultures obtained by curettage or biopsy are more reliable than surface swabs. Sometimes surface swabs can be very do not give that required results, but curettage or biopsy lesions yield better for culture. And then, as we all know, wound bed preparations and debridement is needed sometimes, and comorbidities need to be managed, and a wound care clinic to a specialized wound care clinic where available would be the best option. Now, with that, we come to the end of the specific manifestations. Now, let's move on to the non-specific manifestations. The non-specific manifestations are manifestations which are not specific for diabetes but can occur in other diseases. But when we see these manifestations in the skin, it's important to serially follow up patients for development of diabetes. I'll just read them through and then go with some of the common ones and give you some pictures because pictures speak better. Acanthosis nigricans, cirrhosis of the skin or drying, diabetic-associated pruritus, which is a very common condition, acquired perforating dermatosis, ichthyosiform changes. We also see a lot of eruptive xanthoma, sometimes acrocodons or skin tags, the finger pebbles or Huntley's papules, keratosis pilaris, redness of the hands or palmar erythema, red face or rubeosis facie as they call, yellowing of the skin, nails, onychocryptosis, and sometimes telangiectasias. These can all be non-specific manifestations. So we'll go with the acanthosis nigricans, which is one common one, which is more commonly seen in darker skin types. We don't see it much in the fairer skin types. And this can present in preclinical stages of diabetes even before a clear diagnosis is possible. And prompt and ongoing evaluation is recommended whenever we see patients. I have had two teenage patients in my clinic who came to me for acanthosis, and then on testing, they were diabetic. The pathology is increased insulin-like growth factor, And hyperinsulinemia can cause proliferation of keratinocytes and fibroblasts, and that is responsible for the pigmentation and the velvety nature of the skin, mostly in flexures. We see it behind the neck in skin folds, axillary area, and skin fold area. Management usually is, of course, controlling the diabetes, and pharmacological adjuvants, metformin, when we add them on, it helps, and lifestyle modifications. For dermatological therapy, we sometimes give retinoids, topical keratolytics, just for the cosmetic improvement, and sometimes depigmenting agents help. Now we move on to this very common but yet resistant to treatment condition in diabetes, pruritus in diabetes. Pruritus in diabetes is usually localized to the scalp, trunk, ankles, and feet, but we often see a generalized pruritus too in patients with diabetes. The risk factors include older age group and a longer history of the disease. And it's mainly the peripheral neuropathy. It's like a neurogenic pruritus which happens in diabetes. So mostly people who have peripheral neuropathy also have this recalcitrant itching, which can sometimes be difficult to manage. They also have associated kidney disease and uremia. Those kind of things can also increase the already existing pruritus, and higher fasting blood glucose levels. Treatment options are difficult, like I said, and then sometimes we do topical treatments with capsaicin, ketamine, amitriptyline combination, and then neuropathic pain medications are also needed, like gabapentin, pregabalin. Sometimes we also give very low dose doxepin for these patients. Now I'll show you some pictures which would be better. Acrocodons are skin tags, especially axillary skin tags. Multiple axillary skin tags makes us sometimes wonder if the patient is diabetic. One or two is okay, but when you see multiple, like 10, 20 skin tags, especially in the axillary region, we need to think of diabetes. Eruptive xanthomas. Xanthomas are very yellowish, erythematous reddish, very well-defined papules, which can present in diabetes. Sometimes they're confused with molluscum, which is an infection. Ichthyosiform changes or dry skin. You can see the fish kind of appearance. This is also very common in diabetic patients. They're also on multiple medications like cholesterol-lowering medications and statins, which can again increase the drying of the skin and ichthyosiform changes. Keratosis pilaris is again a perifollicular inflammation which can occur in the arms and back. This is also a finding which we see in diabetic patients. Now we come to the part 3 of the presentation. I'm just going to do a passing mention of some of the diseases, primary skin diseases, which show a greater association with diabetes. So these diseases and diabetes sometimes coexist in patients. They are generalized granulomedullary. Psoriasis is very often associated with diabetes and cardiovascular disease. Lichen planus, vitiligo, and hidradenitis suppurativa, which is an inflammation of the apocrine glands, which is also associated with diabetes. Skin infections, very many skin infections are always have higher association in diabetes, including erysipelas, cellulitis, folliculitis. We also see more of MRSA colonization, pseudomonal infections like otitis externa, pseudomonal infection of the toenails. Sometimes we also see erythrasma and very severe infections too, like necrotizing fasciitis, which need immediate attention. In the fungal category, the most common one would be Candida and Candidal intertrigo, which we often see in these patients. As you can see, this is a Candidal intertrigo in the interdigital cleft, and you can see it's a reddish lesion with like a whitish discharge, and we can see a few like satellite kind of thing. So this is a typical Candidal intertrigo. Now coming to the last part, anything with diabetes is not complete without addressing the adverse cutaneous reactions to diabetic medications and diabetic management devices which have been in market for some time. So the drug-induced category, I have classified the categories of diabetic medications: insulin, biguanides or metformin class, sulfonylureas, meglitinides, and the new ones in market, GLP-1 receptor agonist and SGLT2 inhibitors. And then finally, the contact dermatitis from the wearable devices, which include glucose monitors and insulin infusion pumps. So insulin is the most commonly studied, but fortunately, there are very few adverse reactions to insulin. And the only side effects are very local, and we see sometimes lipatrophy at the injection sites. But with newer recombinant human insulin analogs in market, it's very rare to see this lipatrophy at the site. Sometimes we also see insulin-derived amyloidosis, which is a very rare side effect, and it's usually reserved to cutaneous amyloidosis. And then also be biopsy, and then it's just like a secondary cutaneous amyloidosis. Now coming to the category of biguanides or metformin. Metformin has been a medication which has been used for a long time. It's also used as monotherapy, if I understand right. It's a non-specific rash which commonly seen. Just like any medication can cause rash, so drug reactions are in the differential diagnosis of any rash that happens after a medication. Pruritus and hyperhidrosis are some of the three common reactions which can occur. We also see immunological reactions. They can vary, but among them, leukocytoclastic vasculitis are also reported. We have seen case reports of that. And other generalized maculopapular rash, photocontact dermatitis, and Rett syndrome. Severe forms can also occur. You can see in picture, the lady has a photosensitive dermatitis. It looks somewhat like a lupus rash. And this could be a photocontact dermatitis with photosensitive element after administration of metformin. Now coming to the sulfonylureas. Sulfonylureas can also have drug reactions, mostly in the xanthimatous and psoriasiform category. Sometimes, rarely, we see pustulosis and severe reactions like TEN and SJS. Lichenoid reactions are another common side effects which sometimes we see with sulfonylureas. The issue with lichenoid reaction is sometimes there's a confusion whether it is a primary lichen planus or a lichenoid reaction. Clinically, we have some features to differentiate between the two, and a biopsy sometimes helps to know if it is primary lichen planus or drug-induced lichenoid reaction. Now we come to the meglitinides. Meglitinides too, we have some adverse side effects like rash, pruritus, and hyperhidrosis. Another important thing would be pemphigoid or drug-induced pemphigoid can occur with meglitinides, and then there is like a confusion with the bullous pemphigoid. But that's also one thing which needs to be kept in mind. Any onset of blistering reactions which look like bullous pemphigoid could be a drug-induced reaction. Now we move on to the other category, GLP-1 receptor agonists. They have also been newer in market, and we have been seeing more cutaneous side effects to these medications. And this class would be one of the class which is associated with the largest number of adverse cutaneous reactions. We don't know if it's because it's more reported, but xanthimatous reactions and urticarial reactions can occur. And one thing to be kept in mind is blistery skin eruptions are very common, and it could appear as a very late reaction, even after many weeks of administration of the medication, that sometimes we do not suspect it's a drug reaction. In my clinic for the last year, I think I have seen 2 drug-induced bullous pemphigoid from this category of medication, which resolved after stopping the medication. Now we come to the other category, SGLT2 inhibitors. These are again newer diabetic medications, epagliflozin and dapagliflozin. They also have increased risk of cutaneous and subcutaneous infections. Fourniers gangrene, which can happen in diabetes, but it's otherwise rare. But we have seen that there are many reports of Fourniers gangrene coming in after the start of these category of medications. Genital infections, yeast infections, I think urinary tract infections, and even severe infections like necrotizing fasciitis can also occur with this category of medications. We also have urticaria, rash, and eczematous lesions too. Now we come to the last category of adverse cutaneous reactions, which are wearable-induced contact dermatitis. Now, allergic contact dermatitis is a very common reaction which can happen to devices, but most of the time they are underreported because they are very mild and what we categorize as a minimal mild reaction, which patients manage by themselves. So it's underreported, but it's actually very common. And this can happen with the devices used, which include continuous glucose monitors as well as the insulin pumps. So daily use of these devices can be problematic for this subset of patients who have to use these devices on a daily basis. Another important point to note that we can have also a pre-existing disease like eczema or psoriasis or any other skin condition flare at the site of contact of these devices. It's not a contact allergy, but some other primary cutaneous disease flaring at the site. So that also should be in consideration. So the wearable-induced contact dermatitis, it can be either present in the functional units where we have the sensors and all that, or it can also be in the adhesives. But more commonly, it is found in the adhesives than in the functional units. So the metals usually used in sensors are like metals like platinum, iridium, and silver, which are usually very inert metals, and we don't see much reactions. But the more common reactions are due to the adhesive units like acrylates. Acrylates are a broad category of chemicals which can cause contact allergic reactions. And in the wearables, the most common form noted was isobornyl acrylate. It's IBOA, and it was voted the allergen of the year 2020 by the American Contact Dermatitis Society. Methacrylates could also cause, and other causes of allergens are alcohol wipes, colophony, and nickel, which is not so much used now. So, but I think acrylates would be the major category of the wearable-induced contact dermatitis allergen. Coming to the management of the adverse cutaneous reactions to wearables, there are various strategies that can help and resolve the reaction. Mild reaction, sometimes we have, which the patients would have already done, like they would have attached device to a different site because some areas are more sensitive, some areas of the skin are more sensitive than the others. So attach device to a different site, change the sensors. It's easily said than done. But again, other treatment options include applied corticosteroid creams, barrier dressings or sprays could be used, and switch to a device that does not contain the culprit and allergens. We have never had such a case before, but I think manufacturers usually clearly list all the materials included, and we could contact them and ask for a switch to another device or without the culprit antigen. Referral for a patch testing would be very reasonable when you suspect such a rash. Collaboration between specialists is also very essential. At McMaster Children's Hospital, we have a very busy patch test clinic running throughout the year. So if you have any suspicion of any contact dermatitis to any of the ingredients or in diabetic patients, you could refer to us. So coming to the general approach, in general, to managing diabetic skin. So good skin care, as people always think, it's not a luxury, it's a necessity, especially in diabetic patients. And the primary goal of the treatment is to maintain the skin barrier. So skin integrity, maintaining skin barrier and skin integrity can be a good investment, and it can prevent a lot of complications in future. Moisturization is one thing which studies have shown that diligent moisturization tremendously decreases the risk of skin breakdown, and moisturizers and emollients can play a very major role in preventing complications, especially ones containing urea and lactic acid, because they also have keratolytic effects and that they help in maintaining skin barrier. Patient education is the key. Educating patients regarding good skin care, moisturization, daily examination of the feet, all can be good investments. Regular skin examination always enable prompt detection and treatment of complications, and timely specialist referral would also be advantageous. Sometimes both the patient and the provider are more concerned about less important things. I wouldn't say not important, but less important things where we must really be taking care of we must be addressing the important things first. So in conclusion, to conclude, I think diabetes is a disease. Just like it affects all organs of the body, it also affects the largest organ of the body. And increased awareness and familiarity with the cutaneous signs of diabetes and their morphology can enhance diagnostic workup and better manage our patients with diabetes. The underlying cause of the rash, just to come to a diagnosis, can sometimes be very difficult or elusive because the presentation of skin changes varies from very subtle to very drastic, and also it can appear at any point in the time course of the disease, as I discussed with some medications, reactions can appear very late in the disease. More and more reports of adverse cutaneous reactions related to anti-diabetic drugs and wearable devices have been appearing in literature. And I think we must be more aware of the new medications and their adverse cutaneous side effects. Thank you all for joining me in the session, and I hope it was useful to your practice.
Thank you very much, Dr. Pathayappura, for this overview. It felt like it's an overview of dermatology, and like literally everything is covered somehow within this. So fantastic. Thank you. Really very informative. If you have any question, please put it into the Q&A section, or if you'd like your question to be asked in person, please raise your hand and I'll bring you in. I was thinking, with so many conditions are actually somewhat related to or connected with diabetes, whether it's a specific or non-specific. Do you have like a general approach to, like, when, as an internist, when you see a skin lesion in a diabetic patient, when do you start thinking that this is most likely related to diabetes versus it could be some a separate disease? And when do we trigger a referral to dermatology, more or less? I know that's just a big question to cover, but do you have a general approach to, like, when should we refer those patients versus blame diabetes and work on diabetic control as much as possible?
I think for most of the non-specific manifestations, when we see them, we just do a testing. We just do an HbA1c, or we just screen them for diabetes and then let them know that this could be, pre-manifestation of diabetes. So they are, taught to monitor their blood glucose levels, and if it's like teenagers, they need to be at least doing annual examinations with their family doctor and see if there is a diabetes coming in on the way. But for the specific manifestations, especially the ones like the necrobiosis and all that, they require treatment, and sometimes they really need a dermatology assessment, because sometimes we may have to do biopsies. There may be malignant changes going on, or we may have to address it from a dermatology clinic with other medications like corticosteroids, or sometimes we may have to do infective management, etc. So that is one thing when we could refer to dermatologists. And also with the medication, sometimes there's a confusion whether it's a primary disease or whether it is a disease due to the medication, drug-induced cutaneous condition. In those times too, we could make a dermatology referral, because sometimes we could do a biopsy and other things to know if it's like a drug-induced or like rule out if it's a primary dermatological condition, because the management is different.
So thank you very much. That's really very concise and good way to think about the referral to dermatology, which is sometimes you wonder how when would you do that. I'm fascinated by the diabetic foot, being so at least in acute medicine, we see it so much as well as in primary care. And we always struggle on where those patients are best followed and managed. What do you see the role? I mean, there's a lot of work that primary care has to do, a lot of work that dermatologists could do for a diabetic foot. But where do you see the role of a dermatologist in managing, following up, or treating diabetic foot, if any?
Yeah, so the primary care providers could always refer to us when it gets out of control or when they think they need to do like a culture or swab or like anything to that. But most of the time, the patient education, role of moisturization, checking the feet, and everything goes to it's the role of the primary care practitioner. A referral to a dermatologist would be one major thing would be to do a culture to know the organisms involved, or if there is a differential diagnosis. Sometimes other conditions like pyoderma gangrenosum or other foot ulcers, vasculitic ulcers, or vascular problems can present differently. So whenever there is a difficulty in diagnosis, a referral to dermatologist would be important.
Thank you. I'm not seeing other questions. I'll take the advantage of this, and I'm going to ask more of my questions as we learn more about this. In terms of the diabetic medication adverse effects, skin manifestations, that I was fascinated to see that the GLP-1 inhibitors, causing bullous pemphigoid. And how common are these manifestations? Especially with the use of those medications maybe more common. How common do we see those adverse skin or cutaneous manifestations of those drugs?
I think it's not easy to comment because they have been in market only I think in a few years, and also there have not been many reports. But with my experience in the last 1 year of my clinic, last year I saw 2 patients who were on GLP-1 Ozempic, and then they had the blistering reactions. The worst thing with that was it started very late. They were put on the medication, and I think it was after around 20 weeks, which they started developing the blistering rash. And then we did a biopsy, and then we ruled out the other primary bullous pemphigoid kind of thing, and then stopped the medication. And it took a while, but it took its own time, and then the lesions have resolved. So I don't think I can comment how common, but we are seeing more and more of these cases.
Are there any, and just because I've been also informed about one of those, a patient who has experienced that, and it was a really difficult diagnostic process for her. Is there any microscopic manifestations specific to this GLP-1 medications versus other forms of bullous disease?
Yes, sometimes pathologists give us a better clue if it's a drug-induced reaction or a primary bullous disease. Sometimes we see eosinophils which point towards drug-induced reactions, which we don't see in the primary condition. And immunofluorescence also sometimes give us a better idea with the immunofluorescence. We can distinguish if it's a drug-induced or if it's a primary bullous condition. Clinically, it's difficult, but there are some minor clinical findings like involvement of the oral mucosa, which we see more in some kind of primary disease more than in the drug-induced one. So there are some clinical hints, but it's not always possible to distinguish. Biopsy helps. The only way is to stop the medication and see if the patient is getting better.
It's very helpful. Thank you very much for clarifying and answering all these questions. I don't see any other questions from the audience, so and I don't have any more questions. So what we'll do is we'll give our audience some time back this afternoon. And again, Smitha, Dr. Pathayappura, thank you very much for this presentation. A great overview of a very important manifestation of a very common disease and very useful for us appreciate your presentation today, and thank you very much. And I wish everyone a good rest of their day. Thank you.
Thank you very much for giving me this opportunity to talk to you today. And I hope it was useful for all of you.
Fantastic. That's very useful. Thank you. Bye-bye.